Before we do anything today, we are going to take a quick test. In 30 seconds, you will know exactly how much your autonomic nervous system has been affected, and whether an undetected autoimmune disease might be behind it. No equipment. No standing up. Just honest answers. You are starting with a perfect score of 5 points. I am going to describe 5 symptoms. For every one that applies to you, subtract 1 point. Ready? Number 1. Do you feel your heart racing, pounding, or jumping when you stand up from a chair or bed? Even when you have not exerted yourself at all? If yes, -1. That racing heart is not anxiety. It may be your autonomic nervous system losing its ability to regulate blood flow the moment gravity pulls blood away from your brain. Number 2. Do your hands or feet burn, tingle, or feel numb? Especially at night, or in heat? If yes, -1. Burning pain that gets worse in warmth is a hallmark of small fiber neuropathy, the most common nerve complication of the disease we are going to talk about today. Number 3. Do you experience crushing fatigue and brain fog that does not improve with rest? Not tiredness. Not sleepiness. A heaviness that sits behind your eyes and makes it hard to find words, finish thoughts, or feel present in your own life. If yes, -1. Number 4. Do you have dry eyes or dry mouth that your doctor has never fully explained? Not occasional dryness. A persistent, uncomfortable dryness that eye drops and water do not fully fix. If yes, -1. Number 5. Have you been diagnosed with POTS, fibromyalgia, ME/CFS, or small fiber neuropathy, but despite treatment, you are still not getting better? If yes, subtract your final point. Now, look at your number. If you scored 5, your autonomic nervous system shows no red flags today. This video will help you understand what to watch for. If you scored 3 or 4, your body is sending early signals. This is exactly the right time to learn what may be driving them. If you scored 2 or lower, pay very close attention today. But do not be discouraged. Be excited. Because the lower your score, the more dramatic your improvement can be, if the right cause is found and treated. Pause the video right now and write your score in the comments. Just your number. Nothing else. This will become your day 1 number. In a few weeks, after you have taken the information in this video to your doctor, I want you to come back and update it. People are reporting real changes. And your comment might be the thing that convinces someone else to start. Here is what we are doing today. We are going to show you the disease that is most likely hiding behind those 5 symptoms. One that affects 4 million Americans. Takes an average of 10 years to diagnose. And is almost never screened for in standard POTS or fibromyalgia workups. We are going to show you the brand new 2025 clinical guidelines that are finally changing that. And we are going to show you something that stopped us when we first found the research. One patient had over 85% nerve fiber loss. 6 months after the right treatment, her nerves were back in the normal range. The nerves grew back. Stay with us. By the end of this video, you will have a checklist for your next doctor's appointment. A step-by-step understanding of the treatment options now officially recommended. And a very good answer to why you may not have been getting better. I've pulled real patient stories, real US data, and expert-backed diagnostic clues to help you figure out what your symptoms are really telling you. And if you want my downloadable symptom map, just type symptom map in the comments. Let's get into it. She had been sick for 3 years. Racing heart. Burning pain in her hands and feet. Exhaustion so heavy she could not lift a glass of water. Brain fog so thick she could not finish a sentence. The doctors had answers. Just not the right ones. Anxiety disorder. Fibromyalgia. Just POTS. Learn to live with it. But it was not anxiety. It was not fibromyalgia. And it was not something she just had to live with. Her immune system was silently destroying her nerves. And no one had thought to look. 4 years, doctors told millions of people that their racing heart, burning nerve pain, and crushing fatigue were just anxiety, or fibromyalgia, or just POTS. But a neurologist and brand new 2025 clinical guidelines are saying something that could change everything for those patients. It might actually be a treatable autoimmune disease that has been silently destroying their nerves. And the nerves? They can grow back. You have probably heard of POTS. You may have heard of fibromyalgia, ME/CFS, or small fiber neuropathy. But there is a disease hiding in plain sight that may be the underlying cause for a significant number of those patients. And it has been chronically underdiagnosed for decades. 4 million Americans have Sjogren's disease. 80% report brain fog. 54% feel faint or dizzy regularly. Average time to diagnosis, 10 or more years. 7 to 20 times more common in women. Sjogren's disease, spelled Sjogren, pronounced Sjogren's, is an autoimmune disorder. That means the immune system, instead of protecting the body, attacks it. Most people, when they hear Sjogren's, think of dry eyes and dry mouth. And yes, those are classic symptoms. But Sjogren's is so much more than dryness. It attacks the nervous system. It attacks the autonomic system. The part of your nervous system that controls your heart rate, blood pressure, digestion, sweating, and breathing, without you thinking about it. And here is the fact that changes everything. Dysautonomia can precede a Sjogren's diagnosis by years. Your POTS symptoms may have been Sjogren's all along. That means patients who have been living with a POTS diagnosis, without ever being screened for Sjogren's, may have been missing the real diagnosis the entire time. So the question we need to ask is this. What if your POTS diagnosis is hiding something treatable? To understand why this matters so much, we need to understand what Sjogren's actually does to the nervous system. And for that, we are going to get a little bit into the science. But stick with us. Because this is the part that explains why some patients respond dramatically to treatment, while others never get the chance to try. Inside your nervous system, there are structures called ganglia. Think of ganglia as the headquarters of your nerve cells. The place where the actual cell body lives. These are the command centers. Now, most parts of the nervous system are protected by what is called the blood-nerve barrier. Just like the blood-brain barrier protects the brain, this barrier keeps the immune system from attacking your nerves. But the ganglia? The blood-nerve barrier there is weaker. It is more permeable, more vulnerable. And Sjogren's disease has an almost unique predilection, a targeting preference, for attacking exactly these structures. The sensory ganglia. The autonomic ganglia. That is why Sjogren's patients get peripheral neuropathy and autonomic dysfunction together, at such high rates. In fact, Sjogren's disease is the second most common systemic cause of autonomic dysfunction in the world, behind only diabetes. And in young people, particularly those without diabetes, it is the number one cause. The number one cause of dysautonomia in young people is Sjogren's disease. And yet, the average patient with dysautonomia is never screened for it. Coming up, the brand new clinical guidelines that are finally changing that. And the treatment options that are giving patients their lives back. In December 2025, a landmark document was published. The first ever clinical practice guidelines for peripheral nervous system manifestations in Sjogren's disease. 14,000 downloads in the first weeks after publication. In a medical niche. That is a number that reflects just how desperately the patient and medical community needed this. The guidelines were developed by a team of neurologists and rheumatologists. They covered three key areas: individual nerve damage, peripheral neuropathy, and, critically, autonomic nervous system dysfunction. These guidelines carry a message that rheumatology clinics, cardiology departments, and POTS specialists across the country need to hear. Screen your Sjogren's patients for autonomic dysfunction. Screen your POTS patients for Sjogren's disease. And if you find it, treat the immune system. Now let's talk about what that reframe actually means in practice. Because this is the part that many patients have never been told. When a patient comes in with postural tachycardia, a heart rate that shoots up when they stand, the typical diagnosis is POTS. Postural orthostatic tachycardia syndrome. And that is not wrong. But POTS is a description of a symptom. It is not a cause. If Sjogren's disease is causing that postural tachycardia, then calling it POTS and treating only the symptoms is like treating smoke without looking for the fire. The 2025 guidelines make this official for the first time. If there is an underlying cause, find it, name it, and treat it directly. Now here is the checklist I promised you. These are the red flags that should prompt a conversation with your doctor about Sjogren's screening. You can write these down or come back to this section of the video. Number 1. Dry eyes or dry mouth. These are the classic Sjogren's symptoms most people have heard of. But here is the critical thing to understand. You can have Sjogren's disease without dryness. Especially early in the disease course. Absence of dryness does not rule out Sjogren's. Number 2. Small fiber neuropathy diagnosis. This is the most common neuropathy in Sjogren's, affecting the tiny nerve fibers that transmit pain and temperature, and that control autonomic functions like sweating and heart rate regulation. Number 3. POTS or orthostatic tachycardia. If your heart rate spikes when you stand, and no one has screened you for Sjogren's, that is a gap in your workup. Number 4. Brain fog, fatigue, and headaches. 80% of Sjogren's patients report brain fog. Headache occurs in over half. These are not incidental symptoms. They are features of the disease itself. Number 5. Unexplained low potassium levels. This points to renal involvement in Sjogren's. It is underrecognized and underconnected by most physicians. Number 6. History of kidney stones. Also associated with Sjogren's renal involvement. Number 7. Unexplained liver enzyme elevations. Autoimmune liver disease is more connected to Sjogren's than most clinicians realize. Number 8. Family history of Sjogren's disease. This is the single strongest historical predictor. If a parent or sibling has Sjogren's and you have dysautonomia, Sjogren's should be assumed until proven otherwise. Number 9. Altitude intolerance. An underrecognized feature that points to a respiratory component of Sjogren's autonomic involvement. Number 10. Prominent mast cell symptoms. Frequently overlapping with Sjogren's in ways that are only beginning to be understood. And number 11. This one is absolutely critical. If you have been told your SSA antibody, the main Sjogren's blood test, came back negative, that does not mean you do not have Sjogren's. This is one of the most consequential misunderstandings in this entire disease space. Rheumatologists sometimes tell patients, your SSA is negative, so you do not have Sjogren's. But the research shows that test may only be 10% sensitive in the context of neuropathy. 10%. That means 90 out of 100 neuropathy patients with Sjogren's could test negative and be falsely reassured. The real gold standard, especially when blood tests are negative, is a minor salivary gland biopsy. If you run your tongue along the inside of your lower lip and feel those small bumps, those are minor salivary glands. A tiny incision is made, a few are removed, and they are examined under a microscope for signs of immune inflammation. Ask for this biopsy if your SSA is negative and your clinical picture still fits. A negative blood test is not a closed door. It is an incomplete one. To understand what Sjogren's does to the autonomic system, consider what we see on actual autonomic testing. Some Sjogren's patients have blood pressure that drops when they stand. Others have heart rate that climbs, sometimes by 80 beats per minute or more. Some have both. Many cannot sweat properly. One patient sweated only from her feet. Another sweated only from her forearm, a compensatory response because the rest of the sweat system had failed. And critically, when treated with immunotherapy, these readings can improve. Not always to normal, but dramatically. Enough to go from bedbound to attending school. From unable to work, to working again. That is not a story about lifestyle changes or better hydration. That is a story about identifying an immune attack, stopping it, and watching the autonomic system begin to recover. Fix the immune attack, and the autonomic system begins to heal. Coming up, exactly what the new guidelines recommend for treatment, step by step. And the real-world insurance battles your doctor is fighting on your behalf. The 2025 clinical guidelines do something that has never been done before in this disease space. They lay out a specific, step-by-step treatment framework for Sjogren's-related neuropathy and autonomic dysfunction. Let's walk through it. Step 1. Lifestyle and symptomatic management. This is the foundation. Salt loading, increased fluid intake, compression garments, elevating the head of the bed. Medications like beta blockers, fludrocortisone, mestinorn, and 4 saline infusions. These remain important for every patient. They reduce the symptom burden and improve quality of life while the underlying disease is addressed. Step 2. A steroid trial. For patients with progressive nerve damage, the guidelines recommend trialing glucocorticoids to see whether the immune system is driving the neuropathy. If the patient improves, it confirms what we suspected. This is immune-mediated. And it justifies escalating to more targeted immunotherapy. Step 3, and this is the big one. IVIG. Intravenous immunoglobulin. This is a treatment that modulates the immune system, effectively reducing the immune attack on the nerves. The guidelines now recommend considering IVIG or its subcutaneous version, SCIG, for patients with severe or progressive small fiber neuropathy, and for those with autonomic dysfunction that is not responding to lifestyle and medication measures. The recommended trial period is at least 3 months. Step 4. For patients who do not respond sufficiently to IVIG, the guidelines suggest adding rituximab, a medication that depletes the B cells responsible for driving the autoimmune attack in Sjogren's disease. Let's be clear about what this represents. Before December 2025, there were no official guidelines telling neurologists or rheumatologists to screen autonomic patients for Sjogren's and consider immune treatment. Doctors who were doing this, and some remarkable specialists were doing it based on clinical experience and published case series. Now there is an official framework. And that matters enormously. Now let's talk about something that the medical community often does not say out loud, but that every patient in this space needs to understand. Getting IVIG approved by insurance for Sjogren's related autonomic dysfunction is one of the hardest battles in modern medicine. And your doctor is fighting it on your behalf. Usually without being paid for that time. Insurance companies frequently deny IVIG for Sjogren's neuropathy, citing insufficient clinical trial evidence. And they are technically correct that we do not yet have large randomized controlled trials. The gold standard. What they are not acknowledging is why those trials do not exist. They are extraordinarily expensive to run, and the funding simply has not been there. What we do have is documented case series showing autonomic test scores improving with IVIG. We have patients who went from bedbound to functional. We have published expert consensus guidelines, as of 2025, recommending immunotherapy for this indication. One neurologist was placed on hold for 8 hours by an insurance company during an IVIG appeal. They were hoping he would hang up. He did not. That is not an exaggeration. That is a real story from a real IVIG appeal, told by the physician himself. This is the landscape your doctor navigates. And now, with these guidelines, they have an additional tool when they reach peer review. The guidelines exist partly for exactly this purpose. To give physicians documented, published, peer-reviewed language to use when fighting insurance denials. They can point to an official recommendation and say, expert consensus supports this treatment. You need to listen. What can patients do? Understand that this fight is real and ongoing. If your doctor is pursuing IVIG for you, be patient with the process and express your gratitude. And support the patient organizations. Dysautonomia International and the Sjogren's Foundation, who are pushing for the clinical research that will eventually force the insurance companies' hands. Coming up, the part of this story that genuinely gives us hope. The science of nerve regeneration. And what the treatment pipeline looks like for the very near future. Here is the fact that most people, including many physicians, do not fully appreciate about peripheral nerve disease. Unlike the brain and spinal cord, peripheral nerves can regenerate. But only if you stop the attack causing the damage. The central nervous system, the brain, the brainstem, the spinal cord, has very limited ability to repair itself once damaged. That is why strokes and spinal cord injuries can cause permanent deficits. But the peripheral nervous system, the nerves that travel through your body, to your hands, your feet, your organs, those can regenerate. Slowly. But they can. One patient entered care with over 85% nerve fiber loss in her skin biopsies. Her small fiber nerves were nearly gone. She was bedridden. Unable to function in almost any capacity. She began IVIG treatment. 6 months later, her skin biopsy was repeated. Her nerve density had returned to the normal range, toward the higher end of normal. The nerves had grown back. She described the process of feeling the nerves grow back. Unusual goosebumps in places where there had been nothing. Tingling, then sensation returning. The small fiber autonomic nerves, coming back online. This is not a miracle. This is biology. Stop the immune attack. Give the nerves the conditions they need to heal. And they heal. But here is the critical message embedded in that story: time matters. The sooner the immune attack is identified and stopped, the better the chance of nerve recovery. Nerves that have been damaged for years are harder to regenerate than those damaged for months. Early diagnosis is not just helpful. It is potentially life-changing. And the future for Sjogren's patients is, for perhaps the first time, genuinely exciting. Because we may be months away from the first ever FDA-approved treatment specifically for Sjogren's disease. Right now, there are no FDA-approved treatments for Sjogren's disease. Everything used, including IVIG, is prescribed off-label. But multiple agents are in late-stage clinical trials, and some are expected to reach approval in the near future. Here are 5 of the most promising. First, Actionable. This drug blocks a protein called BAFF, which activates B cells. By depleting those B cells, it may cut the autoimmune attack at its source. It could be one of the first ever FDA-approved treatments for Sjogren's disease. Second, nipocalimab. This targets the IgG antibody pathway, reducing the antibody-mediated damage that Sjogren's causes. It works differently than Actionable, giving doctors another option for patients who need a different approach. Third, dazodalibep. A CD40 blocker that reduces B-cell activation and inflammatory signals. A different mechanism again, targeting a different part of the immune cascade. Fourth, tofacitinib. A JAK inhibitor that modulates multiple inflammatory pathways simultaneously. Already approved for other autoimmune diseases, it is now being studied specifically in Sjogren's. Fifth, telitacicept. A dual blocker that suppresses B cells through 2 separate pathways at the same time, offering broader immune regulation than single-target agents. There is a significant caveat. Despite the best efforts of neurologists who advocated loudly for neurological endpoints in these trials, most of them do not measure nervous system outcomes directly. So when results come in, we may not know definitively how well these drugs work on neuropathy or autonomic dysfunction specifically. That is a real and serious limitation. But the fact that we are here, talking about 5 different drugs in late-stage trials, with official clinical guidelines published, and 14,000 downloads in the first weeks? That is progress. Real, measurable, meaningful progress. If you have watched this entire video, you are probably in one of a few groups. You have been diagnosed with POTS, ME/CFS, fibromyalgia, or small fiber neuropathy and feel like something is still being missed. You have been diagnosed with Sjogren's and did not know it could affect your nervous system this severely. You are a caregiver or family member trying to help someone you love get the right answers. Or you are a clinician who wants to do better for this patient population. Whoever you are, here is what we want you to take away from this video. Action Step 1. Ask your doctor about Sjogren's screening. Not just blood tests. Ask specifically about a minor salivary gland biopsy if your SSA antibody is negative. The clinical picture matters more than a single lab value. Action Step 2. Do not accept a negative SSA antibody as a definitive answer. The test can be falsely negative for 10, even 15 years. Push for a biopsy if your symptoms fit the profile and clinical suspicion remains high. Action Step 3. Ask for a referral to an autonomic neurologist. Find a specialist who understands the nervous system manifestations of autoimmune disease. They are not easy to access, but they can change your trajectory entirely. Action Step 4. Ask about formal autonomic testing. A tilt table test. Sweat testing. The Compass 31 autonomic questionnaire. These create an objective baseline and help track whether treatment is working. Action Step 5. If IVIG has been recommended by your neurologist and denied by insurance, do not give up. The 2025 Clinical Practice Guidelines are a formal published document your physician can use in peer-to-peer appeals. That is partly why they exist. Make sure your doctor has them. Action Step 6. Connect with the patient community. Dysautonomia International and the Sjogren's Foundation are doing the advocacy work that makes these guidelines possible. They are pushing for the clinical research funding that will eventually prove to insurance companies, beyond any reasonable doubt, that immunotherapy works for these patients. If you have been told your symptoms are just anxiety, this video is for you. If you know someone who has been dismissed, misdiagnosed, or told to just learn to live with it, please send them this video. It might be the thing that starts them down the right path. Sjogren's disease is common. It is underrecognized. It is underdiagnosed. It is undertreated. And it is, potentially, a treatable condition. The nervous system complications must be recognized. By ophthalmologists. By rheumatologists. By neurologists. By cardiologists who see POTS patients every day. The nerves can grow back. But only if someone looks. Now go back to the beginning of this video and remember the number you wrote in the comments. That number is not a verdict. It is a starting line. Share this with someone who needs it. It could change their life. And if this video helped you, subscribe. We post new guides every week. New research. New answers. For the people who need them most. We will see you in the next one.